Thanks everybody for coming. It's a great event. The conversation in healthcare management has been going on now for several times, and we've had some great speakers. We have a really illustrious speaker today, and I'm going to defer to Alex to do the formal introduction.
Thanks so much, Michael. And so sorry I couldn't be there with you all in person. This is going to be a wonderful treat for everybody, and I could hear the energy in the room as I was waiting there. So a lot of excitement. And Redonda, I just want to thank you. I know you're always busy, but I know this is a particularly a busy time. So thank you so much for coming in person and doing this for our community. I'll just sort of start with the facts, which I think many of you know that Redonda Miller is the president of the Johns Hopkins Hospital, and the hospital has 1,100 beds in the academic medical center and more than 11,000 employees, and continues to grow. It's now more than $3.4 billion in operating revenue with a dual mission of innovation and community care. I very much hope that through the dialogue, you'll learn a lot more about Redonda's background, because it is a pretty remarkable journey, an upward trajectory through the medical profession. And then, of course, there was the favorite part of her background of getting her MBA at the Carey Business School and transforming her career into being much more on the administrative side and incredibly successful. As I said, I hope that all of that will come out in the discussion. Redonda is such a well-respected professional within the medical profession, and is a member of the National Academy of Medicine. But I can tell you that she is just such a highly respected leader in Baltimore, and is viewed with such high respect and known to be not only a successful leader, but also a very warm and kind person. And so you're in for a treat here. And again, I'm going to enjoy listening on here in the background. So I'll turn it back to you, Michael.
Okay, thanks so much. So again, thanks for coming, and looking forward to the chat. So we'll talk for about 45 minutes, and then we'll have a Q&A session at the end. So I want to start by just getting a little bit of a flavor of the president's role. And can you tell me a little bit about for what are you responsible, and to whom, and what does your typical day look like, and then maybe what does a typical month look like?
Sure. Well, first of all, Dean Trantis, thank you for that incredible welcome and introduction. It is a treat to be here. And he was not wrong when some of my favorite time was getting my MBA part-time at the Carey Business School. My colleagues and I are still friends. One of my teachers runs Rochester Health. Another was our senior VP for HR. Another led quality and safety. So everyone in my cohort went on to such great things. I landed, to your question, as president of the Johns Hopkins Hospital, and I think I have the best job in medicine. And I'm not just saying that. It is fun. There are certainly days that you don't think so. Of course, we all have that. But in general, what I love about being president is the variety, the number of topics that come at you. I'm a general internist by training. So by definition, when it came time to specialize, I didn't want to give up the heart and only do the lungs, or only do the liver and not touch the kidneys. I didn't want that. I wanted it all, the variety of the organs. Well, that translates well into business and your future careers. In my role, I run one of 6 hospitals in the Johns Hopkins health system. And we like to say we're the biggest, we're the flagship. My colleagues get mad at the other hospitals, but we are about 5 times the size of the community hospital. I report to the health system president, a gentleman named Kevin Sowers, and he has responsibility for not just the 6 hospitals, but we have other books of business. We have a Johns Hopkins Community Physicians Network. We have a home care group. We have a payer arm that has various insurance products, and he's responsible for all of that. And then he reports to, obviously his board, we all report to our own boards, and also to the Dean and CEO of Johns Hopkins Medicine. I don't know if you guys understand, Johns Hopkins Medicine is a little bit of an artificial virtual construct. It's not a legal entity, it doesn't hire people or sign contracts, but it does really sort of force, and force is the wrong word because we like each other, we're on the other sides of the street, but it really enables and facilitates the School of Medicine and the health system to work together, align our incentives, and all row in the same direction. So that's a little bit about my job.
Okay, great.
And if you want to know, you said a typical day?
Yeah, typical day,
Oh my
typical week,
So
maybe every day is so different.
When I'm asked this question, I like to pull out my calendar and just tell you about today. So, here we go. I started at 6 a.m. with meeting with the Department of Plastic Surgery. And we wanted to update the faculty on various initiatives of the hospital. At 6:45, I quickly ran to Zayed and we met with the cardiac surgery team because we're strategizing on world domination. We want to be the best cardiac transplant and surgery program in the country. And we're at capacity. So we were brainstorming with our colleagues on the faculty about how we can grow, what beds can we operationalize, how do we make sure we have the right perfusionists, and that. Then I ran back to my office for the 7:30 CUS meeting. This is the unit-based safety program. I'm the executive responsible for the adult ED. And we focus on how do we make sure our patients are getting better care in the ED? Are we getting antibiotics to septic patients in a timely fashion? A lot of the conversation was on boarding time this morning. ED wait times are horrific across the state and around the country. So what can we do to help there? Then I had 30 minutes to call a couple patients, look at my notes for here. We went into our capital budget review with the system finance team. And we're talking about, our routine equipment that we have to replace, but also our strategic capital plans. Are we going to redo the ORs in the outpatient center? Are we going to build a new building? Maybe. And so trying to figure out what's our capital plan. Then I came here. I'm going to pop back and I'm going to go into our executive order steering committee, where we have a group across the health system focused on how to handle all the change coming out of the federal government. And so that we're going to focus on that. I am going to grab 2 bites of lunch. I'm going to meet with the communications team. I had 5 talks today, so we're going to plot out what's next week. And then we have to think about communicating for the entire house for our upcoming employee engagement survey. We want high participation. How are we going to generate interest and get the word out? Then I'm going to meet with my office team and do a calendar run, make sure we're all in sync. Then we're going to do a finance town hall for all the clinical directors, administrators, and directors of finance and go through our financials. And then I'm going to run and meet 4 colleagues for dinner right back down here for a work dinner. How fun is that?
I mean, I'm overwhelmed.
And then I'll do email at home, right? Because we all have the email.
I complain about my schedule being busy. I won't anymore.
Every meeting is variety, and this is your future. If you want your healthcare process to look like that.
So you've kind of answered my next question, but I think I'll ask it anyway because I think it's important to think about from your perspective as the president. Aside from financials, like what are the things that you look at? What metrics do you look at? Because you just listed about 5 of them, right? So ED waiting time, septic care, all these things. What metrics do you look at to assess the progress of the hospital?
That's a great question. And, I sort of like to break down metrics into categories. So you mentioned financial, always important. What's our days cash on hand? What, how are we making progress toward operating margin? But then there are a whole bunch of operating statistics. So what is our length of stay? Are we outside of benchmark? Because we don't have a lot of beds. It's a lot of beds, but not enough. And so are we maximizing the use of those beds? We look at occupancy. We look at ED wait times. Are we making progress and getting people? No one wants to be in the ED. So those kinds of operational statistics. Then we look at people. HR. What is our vacancy rate? We have 1,100 vacancies right now. What's our turnover rate? How are we making sure we have the right folks there in the hospital to do the work? Because if you don't, then someone's doing overtime, and that's no fun for anyone. We will look at quality and safety metrics. Every day we're thinking through, okay, what's our mortality? What is our central line associated bloodstream infections or urinary infections related to catheters? What are our unnecessary complications? Like if we did a puncture of a spinal, or not a spinal tap, a chest tap, did we accidentally drop the lung? Did we have unnecessary bleeding after the OR? So there are those quality and safety metrics. And so that gives you a feel a little bit for what we focus on.
You're quite good at answering the question that I'm going to ask next, but I'm
Okay.
going to ask this one as well because it's from a physician in the hospital.
Okay.
And they asked specifically, what strategies are Hopkins Hospital employing to recruit and retain the best people?
We have a myriad of initiatives around this. I mean, you guys all know what happened coming out of COVID. People were burnt out. They had children at home and couldn't work. They had other responsibilities. And so we had the great resignation, and we really did. And I don't use that term lightly. It was. And so to keep the hospital going, we had to rely on a lot of agency labor. So not people we employ, but people we go out to a workforce agency, paying triple the rates, right, to do the same work. And I'll give you a feel for how serious this was. Prior to COVID, my hospital spent $800,000 a month on agency nurses. At the height of COVID, we spent 14 million a month. 14 million a month. That denominator is correct. Now we're back down to around 3 million a month, but the financial hit was really impressive. And having all of that agency labor, well, the nurse may be outstanding. He or she doesn't know your policies. They don't know the team. Healthcare is a team sport. You need to know the environment in which you work. So there were safety concerns around that as well. So we've really focused on recruitment and retaining. And the way we've approached it is foundationally, you have to make sure you're paying market rates, right? You can't underpay people. So we used to do market adjustments, looking at what people are being paid by job class every 2 or 3 years. We do everyone every year. We make sure we're keeping up. We don't want to lose people because someone's paying more. So we try to hit, median market pay, but that's not enough. And some would argue that, well, I think you could argue it's sufficient. There's so much more to what attracts someone to working at a place. What makes you retain people are here? And I would say it's feeling valued. How do you make people understand that their work is important, that their voice is being heard? So we have a lot of effort in our communication around, your opinions count. What can we do to take your suggestions, make sure we're taking them seriously? People also want to grow. They don't want to stagnate. So we've developed career ladders, mentorship programs. We're proud of our Vivian Thomas mentorship program, where we're in the middle of our cohort now. I'm a mentor. We have about 14 mentees. They spend a year with each mentor, and we really groom them. We have payment programs where you can go back to school and get a degree, and we'll pay for it. We'll pay half your child's college tuition. So a lot of incentives to make you feel like, gosh, we like you. We want you to be here. And we want you to have your career here. And then, of course, we grow our own talent. So just like we have residency programs for faculty, we have launched 1 million pipeline programs. We have a program to train surge techs, a program to train radiology techs and pharmacy techs and clin techs that can go into a career in nursing. And we run those cohorts continuously because we think if we train them and they spend their clinical time on the wards and get to know us, they'll want to stay with us. And the answer is many do. Do we do things like retention bonus and sign-on bonuses? Sure, but those are less effective than some of the initiatives I just described.
And so those are all great incentives. So how do you think, how would you assess the culture within the workforce now? Maybe how has it changed? Where is it going?
Such a good question. Oh, thank you. Okay. We have focused a lot on culture. I would like to think that the hospital had a fantastic culture going into COVID. And then everyone was just tired. And so the first 2 years, we really focused on wellness. There are certainly employee programs people can access, an emergency assistance program, counseling, but more than that, wellness. So we stood up our RISE Center. RISE is Resilience in Stressful Events. And we always had a RISE team that could go to a unit in crisis, maybe a patient unexpectedly died, and be there and support the unit. But now we did a whole floor where you can go and sign up and book a massage chair, or we have one of those meditation tables, we have an art room, and we're gonna amp this up in the CMSC. We're gonna do even more wellness. We also decided we're gonna focus. We made a New Year's resolution. We host a forum for managers. We have 750, 800 managers at the hospital. And every fourth Monday of every month, I lead a session where we talk about all the issues. Well, we decided last January in that forum, our New Year's resolution would be joy and positivity. And we're going to focus on joy and positivity because we have a lot to be grateful for. And so we formed a group. I initially called them, it's some lame name, and they renamed themselves Spirit Ambassadors. And it's a group of volunteers, and I gave them a budget, and their job is to figure out creative ways to have fun. So in summer, on one August day, we had pop-up snowball stands. Remember, we're a 24-hour operation. The executives serve snowballs. I had my marshmallow fluff going, and there were lines out the door. You just come and get a snowball and take them back to your team. We did it on the midnight shift, the evening shift. We did a pumpkin decorating contest for Halloween. 80 units decorated a pumpkin. I wish you guys could see this. And then we had boating. We had, it was out in the Peterson courtyard, and cider and spooky music and caramel apples. And we're just focused on how do we really emphasize the positive. And I think it's gaining traction. People love it. They do. And I do too. I had to dress up as Mustard. We had a condiment race, at Camden Yards. And so 3 of the executives, to get everyone to the town hall, we had a race to the town hall, and we filmed the race. It was Mustard versus Ketchup versus Relish, and everyone had to vote who won. I'll send you the video. It's hysterical. I raced in my heels. But it was just fun. So that's what we're doing.
So these culture initiatives, I think, are super important, and I love your enthusiasm for them. When you think about evaluating them,
Yeah.
right? So you said you're investing in these programs, right? If you had to tie it to one output, one metric, right? Would this show up in better retention, you think, or would it show up in hiring? Like, is it just a feeling that prospective physicians get?
I think 2 things come to mind that it would show up in. Yeah. One, the power of the foot. Do people actually show up at these events?
Right.
Do they attend? Right. That I can see. The answer is yes. The second metric that I think we could see the benefit of this, and we'll let you know this March, employee engagement. Every March we do an employee engagement survey. Every hospital does it in our system, and we look at our main score. We look at is our ESAT, our satisfaction survey score, and I would hope that if we're improving culture, it would show up in engagement. We'll see. We do a pulse survey in the fall, but the main one's spring.
Let's shift gears a little bit. I want to talk about a more macro kind of policy question, which is the Maryland total cost of care model. And maybe that's a deep side, but I think this is something that's super important because when I moved to Maryland, I was not aware that Maryland was such an experimental laboratory for, policy and healthcare solutions and the combination of federal and state initiatives. So can you, from my detached perspective, it seems like this total cost of care model is good for like financial stability in bad times, but it's limiting revenue growth in good times. Could you maybe just educate us a little bit about the total cost of care model, what it is, and then how your hospital thinks about it?
Okay, yeah. Just as a background, how many people know the Maryland payment system for hospitals? Are you familiar? We're different. Okay, a few do. Okay, so maybe I'll back up. We, the state of Maryland, have a waiver with the federal government. There were several of these waivers. Ours dates to 1977. Most are no longer, in fact, I think we're the only one still alive today. So hospitals in Maryland are treated differently than the other 49 states. The waiver, so to speak, is a contract between the state and CMMI, which is part of CMS, part of the federal government. It is not a contract. The hospitals are not a party to that negotiation or that agreement. The waiver has had different manifestations over time. the total cost of care model that Michael references began in 2023. No, that's the AHEAD model that's coming up.
Okay.
We have a new name now.
Okay,
But over time, this agreement went from fee for service, typical fee for service, with an agreement that hospitals in Maryland would keep costs lower than the rest of the nation. Then it morphed into total cost of care model, where hospitals were responsible for not just care that happens in their walls, but the cost of care for patients throughout the state, whether they're going to a private physician's office, whether they're in a nursing home or a rehab unit. Patients were attributed to us, and the idea was to partner with these other private practices or nursing homes and figure out how we could work together to keep costs low for patients. All very noble and good. Tricky because I don't own nursing homes. I don't own private physician practices, and they like fee for service. So, it can be a challenge to try to foster those collaborations. That was the total cost of care model. Then we went into GBR, which is part of the total cost of care. GBR is global budgeted revenue. And this was a huge change in 2014 for all hospitals in Maryland. Hospitals are given their revenue budget for the entire year. So I knew in, June of 2024, my revenue for the fiscal year beginning July 1 through this June, it was 3.4 billion. That's my revenue. If I do admit fewer patients, I still get the money. If I admit more patients, I still get the money. And the idea is a noble one, right? We are going to help hospitals keep patients well and out of the hospital. It incentivizes us to embrace population health. And I love that. Hospitals should be doing that, right? We should be focused on that. The downside is if the silver tsunami hits or patients need more care and they're aging, you don't get additional revenue that year. And the next year you get an update factor, which is about 3%. On average, the cost of drugs with all the specialty drugs, that's going up 10-20% a year. And so it doesn't, the flex year over year doesn't keep up with the growth in cost for care that I would argue is necessary care. Certainly doesn't keep up with tertiary and quaternary care, which is what we're doing. The other part you mentioned about GBR that's really nice is if your volumes suddenly drop, i.e. COVID, we had to cut surgeries, right? We had to halt surgeries to make room for COVID patients. Your revenue was preserved. And so that's a very good thing about it. So there are pluses and minuses to the model. Right now we're entering into the next phase. And the state negotiated the next 10 years, which start next January, and it's called the AHEAD model. I can never remember what it stands for. Advancing Health, Equity, and something development. But basically, it's the new ways. We'll still have GBR, and instead of 95% of hospital revenue being under GBR, it'll be 90. So we may have some opportunity to carve out tertiary quaternary, we'll see. And the emphasis is very much in the AHEAD model on population health, primary care, and health equity. And I mean, that's motherhood and apple pie. We pride ourselves on doing that anyway. Despite our academic mission, we really focus on community care for East Baltimore. So we'll see. We would argue, JHH, the health system, that some of the formula that underpin the volume shifts need to be tweaked. Right now, we have a system where if you don't operate as many beds, you still get revenue and your margins grow to 10%. If you choose to open more beds to take care of patients, and we are up 39 and counting just in the last 2 years, your margins go down and you can't fund your capital and your replacement cost or your strategic initiatives. So we'll see. There's a lot of negotiation going on.
That was my kind of follow-up question is how do you think about infrastructure investments in a counterfactual world in which you were not subject to these policies?
Yeah.
How would things be different in terms of where you choose to invest?
We've had to defer a lot of our capital investment. We have, we need a new cafeteria. We need new ORs in Jayhawk to bring them up to a bigger size so they can house a robot. And we just had to keep deferring those because we don't have the cash we need to fund it. Average, if you look at Kaufman Hall, average margin, in the country for a hospital margin is around 3 to 4%. Mine's -1. Based on just pure hospital operations. If you look at AMCs of similar statute, you're getting up around 6 to 8%. So we do have to have margin.
Yeah.
And it is a very sentinel moment in time right now where we're working with the commission that controls rates to figure out how we charge a path forward that allows us to maintain our stature.
So it's interesting that this has been going on. The waiver was initially
Mhm.
from 1977. So Maryland has been a guinea pig for quite a long time, right?
Yeah.
In terms of experimentation. And I'm an economist, so I love
Yeah.
this. It's great.
It's fun. You love it, yeah.
It's really, really exciting.
I secretly love economics, by the way. I was an econ minor. Okay, go ahead.
So why do you think, this may be just speculating a bit, but why have other states not been subject to this as well? Why is it that for 40+ years, it's Johns Hopkins that has to, or Maryland that has to be the guinea pig?
I don't think their hospital industry buys in because, you know, as the commission, the only lever you have is charging authority for hospitals. So if you look at the last 5, 6 years and see where costs in Maryland have grown and not grown, hospital costs are well below the national average, well below. Outside hospital costs are well above the national average. But if you have to fix it and under total cost of care, keep all costs for Maryland patients below national average, the only lever you can pull. You can't control nursing home physician costs, surgery center costs. You just keep depressing what you pay hospitals. And so I think that is pretty much a very existential moment for us right now about how we can continue to fund. I will say, as a hospital, we focus on expense reduction. You know, it's not just about revenue. As a hospital, I'm accountable to make sure our expenses are well controlled. We had a consultant come in 2016. We had another Navigant. We had another consultant come in 2019 and 2020, Deloitte, and really go through every part of our business. Where are our opportunities to get rid of waste? And what they found is, you know, on a book of business of $3+ billion and maybe 35 million we could do in one area. And the rest is opportunity for revenue growth, which you can't do in Maryland. Growing transplant doesn't bring you revenue.
So a follow-up question that differentiates Hopkins from maybe Mercy Hospital or other hospitals that are subject to this is that Johns Hopkins is a global entity.
Yeah.
Right. And so I spent last week in the Middle East developing our global collaborations in Saudi Arabia and the UAE. It was a fascinating trip and it was great for the Carey Business School.
It's great.
What fraction of your time is devoted towards global initiatives?
Mhm.
And do global initiatives help you with this revenue problem?
So that you have such good questions. The answer to the latter is global revenue having global patients would help us. We're full. This morning, there were 111 patients in the ED. 37 had been waiting more than 24 hours for an inpatient bed.
Okay.
Where would I put international patients? Because they are fee for service. I just don't have room. So yes, we could grow the international business. And I work with my colleagues, Dr. Charlie Wiener, all the time on how do we serve both missions, right? How do we take care of Baltimore, but at the same time, not lose our regional, national, and international reputation? A lot of, and I don't in any way pretend to speak for Johns Hopkins International. It's its own book of business with its own president, and they're wonderful. I've gotten to work much more closely with them. I serve on the board of managers for our joint venture with Aramco. So we have Johns Hopkins Aramco Health.
Saudi Arabia.
Saudi Arabia, yeah, the oil company, you know, and we sit with the oil executives and it's so fun. But 10 years ago, they decided, you know, they take care of their own employees and all of their employees' family members. So they have 300,000 covered lives. They have a hospital they own and operate, clinics, and they partner with other hospitals and clinics, all in the eastern province of Saudi. Well, they felt, we're oil executives. We need some help taking care of our patients. So they partnered with Johns Hopkins International and agreed to do a joint venture where we bring our expertise to Aramco, help them run the hospital. We're doing a CEO search right now to run that venture and be boots on the ground there. If any of you are interested, I want a big leap. So I've gotten to travel there 4 times a year, and it's just been a fantastic partnership. And they pay for the services, so the revenue goes to, the School of Medicine, and it's a win-win for everyone. We do other similar joint ventures. The philosophy of Johns Hopkins International has been partnering with local governments in other countries to help them build up their infrastructure and capability, and spreading our knowledge and expertise. We're excited about centers of excellence, which we're going to bring. We're focusing on oncology and heart and vascular first with the Aramco Health. And so we have folks on the faculty at Hopkins. Ken Cohen is leading some of that effort. He was my Carey Business School classmate, just so you know, another plug, who's going over a lot to work on centers of excellence and develop that. And so if we can replicate that, we do a lot in Panama. I won't pretend to give you all those locations, but it really is a good book of business that I would argue we need to grow. And certainly bringing international patients here for high-end tertiary and quaternary care at JHH makes great sense.
Great. So you mentioned, so let's pivot, because you mentioned the Carey Business School.
Okay.
And one thing that I'm curious about, you were a successful physician. Why pivot? Why seek out business education?
Well, thank you. I don't know if that's true or not, but thank you. So to give you a little bit of my background, I grew up in Ohio. I never knew what I was doing. I never had a 10-year plan. So for those of you in the room that don't have a 5-year plan or a 10-year plan, good for you. Opportunities will come open. I ended up here. So funny. One of my classmates at Ohio State, I went to Ohio State, go Buckeyes national championship. Thank you. We're still living that dream. Still, I walk around every day. Like, we just lost our offensive coordinator and our defensive coordinator. And I'm like, so anyway, I ended up at Hopkins because someone said I should go apply out of Ohio. I didn't know Hopkins existed. I came over from I'm being honest, this was 40 years ago. 40 years ago, I just, Southern Ohio, meat potato, guess who my tour guide was? I get assigned to this woman to take me around, and I loved her. She was so smart, but so normal and just, Katrina Armstrong, she went on to be head of medicine at Penn, Department of Medicine at MGH, dean at Columbia, and now she's interim president of all of Columbia. So she did pretty well. But I fell in love with Hopkins. I joined the faculty after I finished training, and I wanted to be a clinician educator. And I saw patients, I taught, I loved teaching. But around my 30s, early 30s, it was frustrating to deliver care. I saw my patients in the outpatient center. I loved them, but the bureaucracy, the rules, the inefficiencies, and I was an econ minor, I liked finance, I liked all of these topics. And I said, if I went into clinical operations, maybe I could be a part of decision-making that would impact lots of patients and not just one-on-one in clinic. So I went back and did my MBA part-time in the evenings. They had a program at that point that you could do. It was a 4-year program. And I loved it. It was so fun, had different ways of thinking. Finished my MBA. You have to be able to use your MBA. And so I went to my boss, who was the chair of medicine, and asked him for a project. I said, retrospect, perhaps this was stupid, but I said, I don't need money. I don't need a title. Just give me something to do. Just give me a project. He gave me the most unglamorous, crappy project. It was sitting in the basement of Phipps in the dark. That's where the coding team was. And he said, Redonda, go through the charts and figure out how we can code better and what that would mean for revenue. We didn't have an electronic medical record. I went through paper records. I know, I'm old. And then the finance team helped me put numbers, like for instance, someone would write diabetes. If they had written type 2 diabetes with nephropathy, you would be paid more because it documented the complexity of the patient. And so we did some math around it. It turns out we could build 10 billion more a year if we just said the right words. And so it launched a lot of initiatives. It gave me another project and made me as vice chair. The work was so fun, the variety, different topics, rolling out our electronic medical record. And then it led to being vice president of the hospital, vice president for medical affairs, and then the senior vice president for the system, and then my job.
So.
There are take-home messages there, you know. Take-home messages for you guys to be, just go for it,
Well,
you know?
That's what I want to get
Oh,
to, yeah.
okay.
No, so the next, so how would you suggest that business school curricula, especially for people who are interested in health, what emphasis should those programs place on things like data science, like what you were doing, right? Or perhaps soft skills, or perhaps marketing, and where would you place the emphasis in a healthcare management program or an MBA program that's focused on health?
Oh, I love your questions. Okay, so I remember when I sat through the MBA, okay, there was no data science back then. Remember, this was, we'll not let you do the math. It was a while ago. But I remember sitting through some of the hard science courses, the finance, the accounting, the econ, and I loved those courses. I think those are absolutely crucial. Even if you don't end up pursuing a specialty in that area, being able to understand the difference between a balance sheet, a P&L, and a cash flow statement, and being able to be conversant in those types of affairs are absolutely crucial. You must have that. I also remember sitting through, why are they making me take a leadership course? Why do I have to sit through negotiation? I'm never going to use this stuff. Oh. Those are some of the most valuable courses. So if you said, are there certain courses you should emphasize or not? I really think the well-rounded approach, my day-to-day is a negotiation, crafting win-wins for various people around the hospital. The doctors want this, the nurses want this. Radiology wants that, cardiology wants this. Who gets to do endarterectomies? Is it vascular or neuroscience? I'm constantly figuring out how we can get to a win-win. You don't often do it. Actually, I take that back. Most often you do it. There are times where you don't, and you just have to make a hard decision. But learning negotiation was so key. Leadership, change management. Oh my gosh, we've got to centralize the finance team. And everyone in the departments is feeling a sense of loss. I get it. We've centralized things at the corporate system level that I used to have control over. So how do you roll out that change in a way that people feel they've been heard, they understand the rationale for the change, they understand how it's going to benefit them in the short term and long term, how you communicate. I didn't appreciate how important communications was. So to answer your question, I would have a hard time saying one course, and you guys may think something isn't important, but it is.
So one aspect of this negotiation that I think is really funny, interesting, as a non-medical doctor, we're training a lot of non-medical doctors here to work in managerial positions in healthcare. How do you, and you can't necessarily answer this as an MD, but what effective strategies should non-MDs use when communicating with MDs in a negotiation kind of setting?
Okay, I think I have some great pearls here. Having been an MD, I still see patients as I'm still an MD, but also understanding what I have to do now in a more administrative role. And if I could just share with you a little bit how doctors grow up. We are told, from the beginning of training, at least they used to be, and so a lot of your physicians of my generation, just get it done, make it happen, handle it, just deal with it. You're running a code, you're in charge of the code. That patient's life is in your hand, you're calling the shots, when to give epi, when to shock, when to do this. So you have to just get it done. I trained in the Osler residency program, and equanimitas means technically Latin for equilibrium, calm, cool. We used to have a saying among our residents, no, equanimitas means just do it. Don't sit there and complain, phlebotomy didn't show up today, just go get the blood drawn, just do it. So that's how physicians think. They want to just do it. They're focused on, if you're a surgeon, I want the OR to run smoothly. I don't want to wait 3 hours between my cases. I want to help as many patients as I can, get rid of the bureaucracy, and please don't make me sit in a lot of meetings. That's how doctors think. So what you can do as administrators, and what I've tried to do, is figure out, when you're meeting with physicians, explain to them how it's going to get them the time they need to do what they love, which is taking care of patients. How is what we're rolling out going to help you meet what you want to do? This is going to lead to efficiency. We're redoing all the booms in the OR. The booms that have all the equipment. And Redonda, an OR is down. We need all 8 ORs. Okay, these booms are end of life. I can't even buy a replacement part on the black market. So I'm trying to say, guys, yeah, there are black markets for parts, just so you know. I didn't realize that. Black markets, it's eBay on steroids. Like, how can we buy? We have to like install new booms. But in order to do that, that OR goes down 3 to 4 weeks. I'm like, I have patients, I've got to. So, how do we understand, guys? This is how it's going to benefit you in the long run. Actually, remember 6 months ago when that part fixed and we had to wait 4 weeks for the part? That won't happen again. And by doing this, you're going to be set then for the next 10 years. So it's a little bit of 3 to 4 week pain, but the payoff for you in the long run is no more hassle. So you have to really frame it in terms of how they want to hear it. I think that's, and by the way, I consider myself a support function. Our customer is the patient. That is the customer of the Johns Hopkins Hospital. The patient is not here to see the COO or the CFO or the president. The patient came to see the care team. They came to see the doctor who's delivering the care, and the nurses. Our nurses are fantastic, and the clinicians and the pharmacists. That's who they identify with. So we have to, my job is to figure out how I support them in that work. And I say that at every meeting I'm in. You tell me what you need and let me figure out how we can get that done.
So last question before we get to the Q&A. We have a lot of students here who are going to be interviewing for managerial and other healthcare professions. Aside from obvious intelligence and drive and creativity, as somebody who has probably interviewed many people in your career, what are some things that make a candidate stand out?
So aside from the things you said, we're looking for people who are driven, inspiring. I think a couple things I really look for. I said earlier, medicine is a team sport. Almost everything we do, we formulate an action plan in a team. I have my own team, the C-suite, we call ourselves kitchen cabinet. I don't know, it's stuck in a moment of desperation in 2016, but we sit around multiple times a week and figure out solutions to problems together. So I'm looking for someone who's collaborative and has a track record of being able to do something as part of a team. I'm looking for someone who has initiative. There are crappy jobs, and I look across and I say, okay, who wants to take the lead on this? And everyone's like, oh, and then someone will say, you know what, I'll do it. I remember that. I remember that because there are parts of my job every day that is not glamorous and not fun. And there's not a job that's perfect that doesn't have that. So someone who stood up and said, you know what, I'll take that on, I'll make it happen, and it can be hard. And I can give you examples where I did it. And I think my bosses recognize that, whether it's doing something where you may not have the right authority, but you just figure it out, get people in a room and make it happen. So someone who is willing to do that. And then the next great, fantastic project that comes along, I'm giving it to that person. I'm looking for someone who follows up. If, I say, hey, when's a realistic time frame you can get that done? And they say, I need 4 weeks. I want them then to come back. I don't want to be the chief NAG officer. I don't. I want them to come. And sometimes things happen and then you need more than 4 weeks. So just shoot me an email and say, hey, this happened. The part was on delay, or the person I needed to meet with couldn't make it happen. I need 2 more extra. I'm okay. Just someone who can execute, get things done, be part of a team, and is willing to, give a little bit of themselves in areas they may not love.
So before we get to the Q&A, let's thank Dr. Miller. Okay, I think we have a mic that'll come around, but sure, go ahead.
So thank you for sharing it about your day. I'm a second year and PHMBA student, and it was unbelievable that tour de force.
Not every day starts at 6. I don't want to scare people off. Okay, not every day starts at 6. A lot start at 7. Not every night has a work dinner, and we do have work like, okay, go ahead.
What I was like curious about is how you find whether you need time for deep thought
Yeah,
and in like thinking.
yes,
And if so, how do you make time for it? Because it seemed like you were going to, interaction after interaction where
yeah,
you were likely to need to make decisions or even be leading conversations. It wasn't clear to me how you could be prepared for that day.
I think that is so insightful, and my team, we all wrestle with this. Because we like to be present, we like to do rounds every week and be present on the floors. We got 92 units, so it's hard to get to them all. It's so important. So my secret is the 14-hour flight to Saudi is really, really good. There's no email. I can get a lot of good thinking done. But you're right. And I would say that is a huge flaw that I personally need to work on, because you do need time where you can just think. A meeting canceled this afternoon. I didn't tell you that I have 2 hours in between. And I am so excited because I'm gonna go over and really give some thought to this consulting engagement and the options we're pursuing for 200 beds, what makes the most sense. You need that. And if I could pivot too, if you would indulge me, I do fear that I've scared everyone off. This has nothing to do with deep thinking. I make it to my kids' games, my team, we make it, not everyone. But you figure out, I do have a life. I don't do everything. I'm not as good at trash TV. I love trash TV, but we're now doing Young Sheldon. So, and I got Only Murders in the Building. I missed Yellowstone and Downton Abbey, but that's okay. You do have time to prioritize what's important for you. And for the last 2 decades, it's been my kids. And my team knows that I insist they make it to everything important. Do I have a college student I hire to do the running every night? Absolutely. Absolutely. I don't do that because a lot of nights I don't get home. But the important things, everyone knows you never ever miss. You can't get those back. If there's a recital, maybe you're caring for aging parent, whatever. So you can, especially in administration, create some flexibility to have that quality of life.
That was also gonna be my question, actually. I balance everything.
Yeah, and you can't have everything. I used to have a subscription to Center Stage. I don't do that as much. I like to work out a bit more. I'm good on Saturday and Sunday. I'm not as good during the week, but I'm gonna change. I went on my first wellness retreat with 15 other women. This path they've been going every year. And I finally went for the first time in 10 years. It was great. I meditated. I did some yoga things I didn't know existed. I did all kinds of really cool wellness. It was so fun. So you do have to make time to regenerate.
And just to repeat my question, my question was just how you balance everything, especially like as a mother and as a professional and like friendships, is finding that leader.
Yeah, I don't think, was it Cheryl said, someone said, you can have it all, just not at the same time. I think there's some truth to that. I do, and I don't think that's native to medicine. I think it's any profession. I didn't go, like I said, it was my first wellness retreat with the ladies. So I do think you have to prioritize what is important for you at that moment in time and make sure you get to that. So, can I work out every day, watch 3 shows every night, help my kids with homework, make it to the basketball game and play poker on Fridays? No, but I can choose 2 or 3 of those. And I don't feel it's a sacrifice because I love what I do. So work doesn't feel like work. I enjoy work. I enjoy thinking about things at night and doing, believe it or not, doing some email at night because we're contributing to the greater good. But everyone finds, and we try to respect each other's work hours. So my prior COO and I were opposites. I'm an integrator. I like to, do a couple emails while I'm in line at the grocery store, but then go watch a varsity basketball game and then come back and maybe do 6 or 10 emails while I'm doing this. He was a compartmentalizer. And I have my downtime and I'm not gonna answer emails, say after 7 at night until the next morning. And I'm not gonna do it on the weekend except Saturday morning from 9 to 12. And I'm gonna do my work then. There's no right or wrong way. You'll find your own work style. And some people, I try to respect the compartmentalizers and put delays on a lot of emails I send over the weekend, and I delay it until Monday morning, and I choose different times because there's nothing worse than coming in Monday at 8 and so I try to space them out. But we all try to be respectful of each other as a team to make sure we're respecting each other's boundaries.
I can go next.
Mhm.
Thank you for all the insight, first of all. It was really great just hearing everything. So my question is, what do you think changed and what the difference was between the girl, this and over here? What do you think was the difference between the girl who was so uncertain about not having a 10-year plan or a 5-year plan to, a young woman who is shuffling through paper charts, and to who you are now?
I think there's a couple. That's a great question. So what has changed? I think one thing that's changed is just, by the way, I still don't have a 5-year plan. Yeah, I'm not ready to retire yet. I think one thing that's changed is just being open to opportunities that come to you. I used to be scared. I remember when I made it down to the final couple to become the vice president for medical affairs. I had a panic attack. I can't do this. I don't know anything about pharmacy or credentialing. And you learn it. People don't expect you to go into a promotional job and know everything. You learn it. So that discomfort has gone away. So that has changed. The willingness and excitement about embracing new opportunities. I also think what's changed is finding what you really, truly love. And it takes bouncing around a little Brownian motion, so to speak, before you land on it. At the time, I loved being a clinician educator and teaching, but then okay, I love it, but do I want to do this for the next 40 years? I think the answer was no. And so in my mid-30s, I had to take a long, hard look and say, okay, what do I need? If there's something else that I think I might love more, how do I set myself up for that? And it meant going back and doing the coursework for an MBA. But you're going to bounce around. There are all kinds of fun things I might like to do next. So that's what has changed. An openness, a willingness, a curiosity, and the confidence to act on that. I was nervous about joining the Aramco board, the job, women, yeah, oh, piece of cake. We're buds. Everything's good.
So I do have a question in regards to Aramco. So I'm a student in the healthcare management program. I'm
Yep.
also from Saudi Arabia.
Great.
So I've always been very intrigued and curious about more confident in Hopkins integrating together. And I would say my question would come to, what challenges did you face to integrate the policies that are, for example, at JDH to staff? Like, for example, CDCQ has an exhibition policy within 6 hours, but then a cardiac surgical unit at Hopkins and Saudi operated. So what are the challenges and the skills that you needed to?
That is such a great question. Okay, I'm going to preface by saying I'm not the expert. I have been on the board of managers for not quite a year. June was my first meeting, so not quite a year. So the day-to-day integration that you're speaking about, I don't think I'm very expert to speak on that. I will say though, what I've noticed, I went to Saudi, 8-10 years ago when I was vice president of medical affairs versus now. That was an in and out one-time trip. Wow, things have changed. It is fantastic. I love my colleagues who are, the board of managers has 5 from Hopkins, 5 from Aramco, and they're so forward thinking and open, and they want the same things we want. They pay attention to quality metrics. They want to deliver the best care for the people who work for Aramco. They follow RCAs and sentinel events, and they want to grow. So it has been a really nice alignment. The day-to-day integration, meaning we have a policy, I apologize. I don't know if I can speak to that. I think we probably have opportunity to build those policies a little more together and not come at it perhaps, we never want to be, well, our way's the right way. Because honestly, if you go to 6 different CVSICUs in the US, you're gonna find 6 different policies. So figuring out how we meet folks, their situation may be different than ours, and how we still hold patient care safety as the highest. That was not a great answer, but I'm being honest when I don't know the nitty-gritty.
We have time for one more.
Thank you. I'm an international physician and I'm a first year MBA. I'm also in clinical operations. Is there any collaborative in the near future? Is there any collaboration between the hospital and the MBA program to have more projects for us to work on?
It was, we do have collaborations more at the health system level. You guys, I think Kevin had a program where, I don't know if it still exists, folks could do some rotations or no, does that still exist? I don't know, I'm asking the wrong person. We are always open at the hospital to having people who want to come volunteer, rotate. I don't know a formal program, but I can find out and get back to you. Because it is important, what you say is really important to have firsthand experience. Even if you just come and hang out in the ED and do a project with the emergency department, or we've got tons of projects. We should be able to figure out how we can get you the exposure you need.
Yeah, it's been very hard to find something.
Has it?
Yeah.
Okay, that'll make it my homework. Okay, I'll go back and discuss with Michael, see what we can do. And there was
One more question?
Sorry.
Yeah, wait, one quick.
I know they have schedule, I can stay.
Yeah, one, sure, go ahead.
Hi, can you hear me? So thank you for being here. You've mentioned on your talk about the importance of maximizing revenue, making sure you're hitting your benchmarks. But how do you budget and plan for something that you don't know is going to happen yet? You know, mass casualty event, the next pandemic. So but how do you build redundancy and resilience for those events when you're trying to break them?
Oh, you guys have such great questions. Thank you for asking that. We learned a lesson during Ebola. I remember, I was the vice president for medical affairs at the time, and my boss was Mr. Ron Peterson, and Ebola never hit really big in the US, but I remember in Texas, the nurses that were affected, and we're not ready. The Johns Hopkins Hospital, we are not ready should something like this happen. So luckily it didn't happen, but we said, we need to get our act together. And we started, first of all, we make sure we have the appropriate days cash on hand, that we're sustainable for appropriate length of time. If you take in short-term investments and long-term, we're well above 100. If you count long-term investments, heaven forbid we have to liquidate, we're fine. So we have good cash reserves and short-term. But there's more to it than that. When Ebola hit, we said, okay, what do we need to do? How do we be forward thinking? We made the decision, one, to build a biocontainment unit. It's a jewel. It's up at the top of our buildings. We are one of the 10 regional centers of excellence sanctioned in the US. We train people, and every once in a while we'll get a call from DC and say, we think someone may have something bad, secret, we're sending them to you, are you ready? Our Lifeline trained AMBO team is trained how to garb, don, doff, keep everyone protected, go get the patient, bring them, send them up the back elevator, and open up our BCU, biocontainment unit. We also, in 2012-ish, at the time of Ebola, decided we would stockpile 200 ventilators and 2,000 PAPRs. PAPRs are the hoods that you wear that are negative pressure to keep your staff safe. So when COVID hit, guess what we had in the warehouse? There was not a day that go by that we had to send a nurse to take care of a COVID patient that didn't have the right PPE. We are so proud of that. So proud. Now, there were a lot of patients you didn't know if they had COVID or not. We had to, and then we shared with the rest of the system too, and we decided to bring, but I would like to think that we learned from that. And we look at this all the time. Do we have the right number of inventory of ventilators and PPE, personal protective equipment? Do we have the right cash reserves? So thank you for that question. We stockpiled Zippo for anthrax. We have it all.
Okay, let's thank her one more time.